Welcome to All Things Chiropractic.
Well, welcome to another episode of All Things Chiropractic. I'm Paul Andrews.
And welcome, I'm Dr. Mark Davini.
So today, everyone, we're going to be investigators, sleuths. It's about code breakers. And what's the deal with manual therapy techniques?
You don't see it, but Paul's sitting here right now with his magnifying glass looking at the paper.
Yeah, right.
And his
Yeah.
checkered hat with two brims.
Yeah, exactly. I am a Sherlock Holmes fan. So, I'm embracing the whole title. But
there you go.
So as someone who's been in the billing side of things for a long time, this code has been the bane of our existence since it came to fruition. It was announced back in 1998. Now, who announced it? AMA, the American Medical Association, maintains the current procedural terminology, codes, and definitions, what we know as CPT codes or service codes.
And it's always a pleasure to have them do things because we know they understand us so well.
Yeah, I dare say that chiropractors aren't really on the cutting edge of their discussions and their panels. We're probably not there at all at the table per se. But, so back in 98, in November, the CPT Coding Assistant publication came out with their Heads Up, which was effective in 1999, January of 1999. There will be a couple of codes that will be deleted and a new code in its place. So the codes before 1999, if you did manual traction, you could code out for it. If you did myofascial release as a technique, you could code for it in conjunction with your primary service, which in chiropractic obviously would be the spinal CMT.
Remember the good old days.
Yeah. Among other codes. But, the AMA decided, in my opinion, the industry decided people are getting paid too well for this stuff. So let's go ahead and consolidate it. That's just my opinion.
How do we stop this?
Yeah.
Oh, my God, they're actually making money out of this,
So they decided to take basically like 6 codes or 5 or 6 codes and say, well, they all now mean this one code 97140. Like, okay, great. So they deleted the 5 codes, said only start reporting 97140, but there are going to be conditions on which you as a chiropractor can report these codes, and we'll talk about that.
This area restriction also applies to osteopaths.
Yeah, it does have, they didn't single out just chiropractic this time.
Right, this time, yeah. Because sometimes we feel like we're the only ones being persecuted, but yeah.
Yeah. So the technical actual definition is manual therapy techniques, mobilization, manipulation, manual lymphatic drainage, manual traction, one or more regions each 15 minutes. So there's the definition itself. And when we're talking about the anatomical site restriction on reporting, as all carriers will say, it doesn't mean you can't do it. We're not telling you the service can't be performed. We're just saying you can't report it and, actually get paid for it.
Because they're really saying in the backdrop, we don't believe they're different. That one consumes the other.
Yeah, there's so much overlap in that service that it's so hard to identify the difference between a chiropractic and adjustment and myofascial release or trigger point therapy or
soft tissue mobilization, manipulation.
Yeah. So basically what both AMA CPT and the National Correct Coding Initiative, NCCI, put out in their guidance is that if you do a chiropractic adjustment in the same anatomical area in which you're performing this manual therapy techniques, well, alas, you cannot report the manual therapy technique on your claim and get paid for it. No matter how long you do it for in that area, no matter how credentialed you are, how sophisticated the service may be, what manual tools you may use in conjunction with it, if you were to adjust in, let's say, that cervical region any manual therapy in that cervical region would be complementary. But you can't give anything away, remember?
No. When you say area, I know. Yeah, exactly, right? Can't do that. But when you say area, what do you mean by area?
Well, it just depends on the area you're in. So if you're in the cervical region, it's going to be anything, basically laterally from the spine. So if you're working on SCMs with manual therapy techniques, that's a courtesy because it's in the cervical area. And if you adjusted any of the cervical levels, you've now discounted the use of reporting manual therapy techniques.
So what about like infrascapular muscles? And I adjust the thoracic, and now I also do myofascial release on an infrascapular.
What about it?
Yeah. What about it, right? Isn't that a different area?
No, but there'll be members that'll split hairs a bit and say, well, I'm working on the rotator cuff and I'm working on a deltoid and I've adjusted cervical and thoracic. What about that? And then, of course, our answers are, well, do you have a diagnosis in those areas? That could be extra spinal. Did you do an extra spinal adjustment? Because that now has discounted the use of manual therapy techniques on the claim as well.
Yeah, which will be a future podcast.
Yeah, I'm sure there'll be plenty of them. And listener feedback will be wonderful on this. I can't wait. Yeah. But hey, so what we're really talking about here is as what I referenced in the beginning, the bane of the existence for billers and clinicians, because you're providing a very valuable service, a clinically justifiable service. And in many cases,
time.
It does. And in many cases, you've got a lot of postgraduate courses that you've done on these techniques that you've spent a lot of time and money on. But yet you're being told by several entities that you can't report those and get paid for them separately. It's sad. I think it's wrong. I think it's unjust,
Oh, absolutely. When you look at these procedures and you think about what it is that it takes to do one compared to the other, they're not the same. Yet somebody who we'll say isn't even in chiropractic, like the AMA, sits there and decides what it is that we do without knowing what we do and how to include that in one code. One code covers everything. It's this miraculous code that I can just do everything that I think a patient needs under that one code.
So let me ask you, Doc, you're a clinician. In the definition of manual therapy techniques, it includes this word manipulation. Now, AMA CPT defines the chiropractic adjustment as a chiropractic manipulative therapy, a CMT. So where is the distinction between a CMT and an MTT, if I can use those abbreviations?
Glad you asked that, Paul.
I bet you are.
This is really a great discussion because it does come down to a lot of, we'll say, subtleties, but certainly there's a lot of subtleties in all branches of healthcare. So if we were to say, look at a physical therapist could easily say we mobilize fixated joints. Chiropractor could say we mobilize fixated joints. So if mobilization is putting movement in a fixated joint, well, we could probably fit under the definition that way. Said if you look at an osteopath, they do manipulation. But a manipulation to an osteopath isn't about just moving joints. They actually do a lot of soft tissue manipulation. So they'll do visceral manipulations and things like that. So the manipulation word really works well for an osteopath. It never really worked well for us, but yet over the years, unfortunately, it has infiltrated our lexicon to the point where people exchange the word adjustment and a manipulation to be the same thing. But we're trying to say, what are the distinctions here? So why is it that we're saying the code 97140 is not the same thing as a manipulation or mobilization? So again, if you think about a physical therapist mobilizing joints, great. You think of an osteopath manipulating joints and tissue, great. For the purpose of what? Physical therapist mobilizes the joint to put more motion in. osteopath manipulates joints and tissues to stimulate circulation. That's the principle of osteopathy, is to keep manipulating to stimulate areas' circulation to promote healing.
Aren't there like a dozen modalities that stimulate circulation?
Absolutely. And they use them all. Okay.
Not to devalue an osteopath service. I'm just,
right.
Yeah.
But they
I'm a
use
layperson.
hands-on, they'll use joint manipulation, they'll do soft tissue manipulation, visceral organ manipulation. But their primary goal is not to just restore motion, say like a physical therapist. Their primary goal is to keep stimulating the areas to promote healing until they've satisfied their criteria. Now let's go to a chiropractor. What do? We adjust a joint. Yes, the joint may be fixated, more than likely. The old saying, all subluxations have fixations, but not all fixations are subluxations.
Now hold on. Subluxations. I don't want to go into it today. I'm sure we'll do an episode on this. But
Absolutely.
So let's steer away from the definition of that for the moment, per se.
Let's just take it on face value.
Yeah.
That we as chiropractors adjust this entity that is a subluxation. So we adjust it not just to mobilize the joint, not just to stimulate circulation, but we do it to remove interference with the nervous system. So a physical therapist mobilizes joints to restore motion, an osteopath manipulates tissue to increase circulation, and a chiropractor adjusts to balance the nervous system. So there's very big clinical differences between them, and doing one doesn't necessarily do the other. And that's the problem here, is that they've taken...
Can I ask you a question?
Yeah, go.
I don't interrupt you, but I am interrupting
Go ahead.
you.
Yeah.
Physiologically, I'm curious about this. So physiologically, you described about 3 different intents, the intention of 3 different clinicians, let's say on the same joint, same area. Physiologically, could you see a difference?
That is a great question. Seriously,
Yeah.
I'm not joking. Because now we're coming down to the differences between not just what we do, but why we do it, which we talked about, and how we determine what we do. So if you were a chiropractor that took a strongly mechanistic approach to chiropractic subluxation, then you could easily fall more into one of the other categories than someone who might take a vitalistic approach. So, for example, in the old original days back, after chiropractic was discovered and B.J. Palmer started developing his chiropractic approach, at one point, they were all upper cervical. They would only adjust C1 or C2 because they would state that in their definition of a subluxation, the only true subluxations are either C1 or C2 or both, and everything else is a compensation. So, and we've expanded the full spine concept of a subluxation beyond that. But still, when we think about that, if a chiropractor is adjusting a subluxation for the purpose of reducing nervous system interference, then that would be a vitalistic concept. We might adjust 1, 2, 3 segments based upon whatever our technique is that determines what needs to be adjusted. But we don't just manipulate for the sake of manipulating, and we don't just mobilize for the sake of mobilizing. And if your techniques encompass that thinking more, then you definitely are moving toward their definition of what 97140 covers. If you're staying more on the vitalistic end of things, where what subluxations you adjust are based upon a strict criteria that isn't just a fixated joint or isn't just for the need to stimulate circulation, but also for the need to balance out the nervous system, now you're doing it for a whole different reason that doesn't fall under the 2 other definitions.
So why do you think AMA decided to bundle in not only the manipulation mobilization, but manual traction in this code?
Well, again, traction is a modality. It's a good modality. I love the modality. I actually did my neuro diplomat on traction. I love traction. But they have a code for mechanical traction, Y-axis mechanical traction, and this just falls under the manipulation, mobilization definitions. If I am moving a joint to improve its mobility, certainly traction is one way I could do that. I can improve a fixation in a joint through traction. So manual traction cleanly falls under the definition of, or we'll say their definitions of manipulation and mobilization. But traction is not an adjustment. So it doesn't fit our definition of what we do, but it cleanly fits the definition of what they're trying to accomplish.
So do you think that manual traction, mobilization, lymphatic drainage that's manual, and this joint manipulation, because they're all under one code, is it that AMA said, well, the clinical approaches are so similar we can code them together, or the clinical outcomes are so similar we can code them together?
Yes, and well, you can see where they try and think that. And certainly as a profession, we need to clearly define the distinctions between what we do and what they do. If that were true, then why do we even have three separate professions? So when you talk about licensure...
Careful. Maybe we won't. Careful.
Yeah, when we talk about licensure, then the licenses clearly define who and what we are. And I'll tell you, for every state law that I've read so far, it includes the adjustment process for at least stimulating and balancing the nervous system, where what they do doesn't include that component. So, yes, I know what you're saying. How we do what we do may look similar. Even what we do from a technique perspective may be very similar, but if our analysis is different, and then that analysis leads to a different process and procedure, which means we determine what levels need to be adjusted, and then we apply an adjustive technique that's specific to that level, then we're doing something very different. So in my mind, one's general, one's not quite so general, but still general, and then we're specific. And our licensures allow us to do that. No other profession can say that they remove subluxations. Only us. So we have to talk about what we do and not focus so much on the how, because you can manipulate till the cows come home, you can mobilize till the cows come home, and still not adjust a patient. So the outcome isn't the same. We have not reduced or minimized that subluxation in any way, shape, or form, yet I manipulate all over the place. And sometimes those techniques interfere with the adjustment, or what could have been an effective adjustment, by overtreating, overstimulating.
So to circle back to why I described this as the bane of a builder's existence, that brings us to our members' moment. And oftentimes our members will communicate with us their frustrations over trying to get reimbursed, even when they're doing it correctly. So what correctly means is that you've done your chiropractic adjustment on a different anatomical area than the manual therapy technique. You've reported it on a claim, and you've used the correct modifiers. Now, 59 has been the popular and only modifier that would be reported for years and years and years. 59 is defined as distinct procedural service. And then they came up with this X set, these 4 X set modifiers, of which XS would be the one that you would pick. It's separate organ or structure. It's a little more specific to really paint you in a corner if you're not coding correctly, because if you're saying I'm doing manual therapy techniques on a different anatomical area, you would report the XS, you would diagnose point correctly, so that it would point to just the diagnosis you're treating on that particular service, et cetera, et cetera. the bane of our existence about this is that even when you report it correctly, there are carriers that will still pen the claim, want to see the notes to make sure you're reporting it accurately. And there are some that I won't name them, but there are some carriers that just flat out say, we don't care if you're doing it according to AMA, CPT, and NCCI edits. We're not paying for it anyway.
Exactly. And this is where the fight comes in. And we're fighting it. Tools of Practice is fighting it. Hopefully others. We have to challenge it because what they've done is they've taken the adjustment and they've made it a therapy. So in our world, we have the adjustment is what we do. It's the primary thing we do. And everything else is a supportive procedure in one form or another. And what they're saying is, now we don't believe that they're separate and distinct services. So when you do this 97140, it encompasses the adjustment. So we don't have to pay separately for it. So that's the problem, is that even sometimes in chiropractors' minds, they equate 97140 manual therapy techniques to be equal to the adjustment. So we have to be clear as a profession. We have to stop watering down what we do. And what we do that's separate and distinct from all other practitioners is that we adjust the spine to remove nerve interference. If you can't wrap your head around that, then you can agree with CPT and NCCI that manual therapy techniques should not be paid for separately from the spinal manipulation that you performed. It's that simple.
So we can't leave today without just circling to one particular scenario which we've seen come up, certainly on our compliance audits and other areas. We see this. A provider says to themselves, well, okay, I'm performing this manual therapy techniques. I should get paid for it. I'm emotionally right there with you, Doc. Right there. Right next to you.
And we're fighting to make that happen.
However, to achieve this financial goal, a provider decides, well, I'll just down code to a 1 to 2 region chiropractic adjustment, and then I will do the manual therapy techniques on the third area. I won't adjust. I'll document it all correctly. I'll bill it all, modifiers, and everything looks great. And you probably will get paid if your prospective system will pay
Seen
you.
it a lot, yeah.
But Dr. Davini, on an audit, and you're looking at this going, well, you're a chiropractor. You decided to do manual therapy techniques in lieu of an adjustment on this area. What question might you have for that doctor?
Well, you'd have to say, all right, what's the clinical rationale for not adjusting an area that needs to be adjusted? And often these notes will identify those areas to have subluxations, and they just didn't adjust it. Or maybe in their minds, they know there's a subluxation there and they didn't adjust it because, again, like you say, they're trying to find a way to get paid here. And I get that also. But when you find a subluxation and you don't adjust the subluxation, then you are basically not doing what you are supposed to be doing clinically, what you're obligated to do clinically. You're supposed to perform the service that's most effective for the condition that you find. If you find a subluxation, the most effective treatment would be a chiropractic adjustment. If you don't do it and you are basically saying, well, I'm getting the subluxation through my manual therapy techniques, then it begs the question, then why'd you adjust the other areas? Why don't you just do manual therapy techniques on the other areas and not even bill for the subluxation? So you can't have it both ways. If there's a subluxation, you have to adjust it. If it's some other type of tissue disorder or just a joint fixation without the other components of a subluxation, then you do the manual therapy techniques. But if you do manual therapy technique in lieu of an adjustment to an area that you've identified as needing an adjustment, that's the 5-letter F word.
So what if I said, well, I didn't even look for an adjustment in that area, so you can't accuse me of not adjusting a subluxation?
We can't
why, right?
Can't justify clinical incompetence. So,
Ooh, there it is.
ooh.
Yeah, right. It goes to my when we do our coding or billing classes. I have this motto that the doctor treats the patient, the claim specialist treats the claim, and then when the
Perfect.
doctor starts treating the claim first, that's when the 5-letter F word fraud comes out. Typically, because you're just trying to achieve, and I get it. You should get paid for what you do. We've been talking about that.
But
right?
if we ask you very simply, why didn't you adjust the subluxation in the cervical spine, yet you adjusted the subluxations in the thoracic and lumbar, what's going to be your reason? I mean, what's going to be what you say? You can't say, oh, I just wanted to get paid more. You know better than to say that. So you're going to come up with this kind of convoluted
What if a patient's hesitant on the cervical spine? There's a lot of patients that are scared.
And then that would be in your notes.
Yeah.
Patient personally requested not to have my cervical spine adjusted. So I performed manual therapy techniques in lieu of that.
Yeah.
That's what I mean. You have to have a reason. If I ask you why you didn't do it, it better be some clinical reason that's different than I just wanted to get paid more. So maybe there was advanced degeneration there. Maybe your technique doesn't allow it. Maybe you have no other technique in your repertoire that allows you to adjust an area other than manual. That may be just your personal philosophy, but we know there's instrument adjusting, you have drop tables, even have breathing assist techniques that a lot of kinesiologists use. So again, adjustments can be performed in many ways. You have to be able to say, none of those, in my clinical opinion, would be effective. So I did it this way instead. And that's not going to be very common. So
Right.
looking and like going back to your question about reviewing, and then you're reviewing 10 and 20 and 50 and 100 patient files, and it seems like all of these people only have 2 areas that need to be adjusted and 1 area needs a manual therapy, there would be no clinical justification for that pattern of behavior.
So to keep it compliant, but also clinically minded, are there other services without this anatomical site restriction that a chiropractor could lean towards to get some good clinical outcomes, but try to avoid this anatomical issue and overlap?
Yeah, and again, that's a great question, because think of something like ART. Well,
Active release technique.
Active release technique,
Yeah.
which you can almost do for either manual therapy technique reasons, myofascial release, adhesions, things like that, or to establish flexibility and range of motion of muscle and joint.
That sounds like a familiar definition.
So if I were to do something to improve someone's strength, flexibility, range of motion, or endurance, and I were to ask my biller, Paul, you're my biller,
Yeah.
what code could I use to incorporate those services?
Well, it's a code that I really, really, really like as a biller, and that is therapeutic exercises 97110 for our AMA CPT people. Getting in the weeds, but this technical stuff I think is important.
Absolutely.
Yeah, that code is there's no anatomical site restriction to therapeutic exercise, which is great from a billing standpoint. I think carriers like it because it's not a passive service that typically the patient is active in that recovery. So insurance carriers like to see that.
Absolutely.
You got metrics with outcome assessment tools to measure it.
So you're doing the myofascial release adhesion work basically for free, but you get to do the range of motion and flexibility work and get paid for it. So at least incorporating procedures that do both may get you paid for one in addition to your adjustment.
Yeah. Right. And so looking outside your normal routine, docs, if you're sort of in a rhythm and finding continuing ed that helps you improve in those areas that are also going to get you paid, there's nothing wrong with that, as long as you stick with the motto of the doctor treats the patient,
right?
The biller treats the claim. Any words of wisdom as we wrap up today?
Well, again, just saying it doesn't make it so. So you can't call it something that's outside of what a subluxation is if it's a subluxation. If it is what it is, you do what you need to do in the way that you need to do it. And like Paul just said, you don't treat the patient based on their insurance.
All right. Well, thank you so much for joining us for another episode of All Things Chiropractic. I'm Paul Andrews.
And Dr. Mark Davini.
Thanks for listening to All Things Chiropractic. We'd love to hear from you. Visit allthingschiropractic.com with comments, episode ideas, or questions. Or connect with us on Facebook and Instagram at All Things Chiropractic Podcast. Be sure to join Dr. Mark Davini and Paul Andrews next time for another episode of All Things Chiropractic.